Hi everybody, and welcome to our module on heart failure basics. Heart failure is a condition in which there is impaired ability of the heart to pump blood, and if you can appreciate this, then you should appreciate that the hallmark of heart failure is a reduced cardiac output. No matter what type of heart failure you have, no matter what the cause, there will be a low cardiac output in any patient that has any type of heart failure. For the next few slides, I'll go through my model of how I recommend you think about the clinical syndrome of heart failure. So I want you to imagine that we have a pump, and this pump is draining water from a tank, and that tank is being filled from water flowing in from a pipe. Now, if the pump is doing its job and it's pumping lots of water forward, the level of water in the tank will be relatively low because as soon as water comes in, it is pumped out by the pump. Now imagine if that pump started to fail and it was pumping less water forward. As a result, the water level in the tank would start to rise because water is still coming in, but the pump is removing less water from the tank. And now imagine if the pump really began to fail, so very little water was being pumped forward. Now the tank would completely fill up and even begin to overflow because so little water is being removed from the tank. Now, of course, this model is just to help you understand heart failure. Inside the body, the pump is the heart. And inside the body, there's no water, but instead there's blood. And instead of a tank, what we have are the lungs and veins. And so this is the way you can think about heart failure. As the pump of the heart begins to fail, less blood is pushed forward. Therefore, there's a low cardiac output. That means that more blood backs up and fills the lungs and the veins. So now that we have that basic model of heart failure in our minds, let's drill down in a little more detail on the pathophysiology. So when chambers fail to do their job, when chambers of the heart don't pump normally, more blood is left behind, as we showed in the last few slides. That blood exerts pressure on the wall of the chambers. In other words, the molecules push on the walls of the chamber and generate higher pressures in the chambers of the heart. So therefore, one of the hallmarks of heart failure is that the pressures may rise in any or all of the cardiac chambers depending on which ones are involved. Let's talk about specific chambers. When the left ventricle fails, this leads to a rise in left ventricular pressure. Now, the left ventricular systolic pressure depends on contractility, and this can be low in some forms of heart failure. But when I say the left ventricular pressure rises, what I'm referring to is the left ventricular end diastolic pressure. This pressure is always high in left heart failure. In fact, a rise in the LVEDP is the hallmark of left heart failure. Remember from Wigger's diagram that the pressure in the left ventricle goes from a low value of about 10 or so up to a peak of about 120 or so and then back down to 10. This peak of 120 depends on the contractility of the ventricle, and in some forms of heart failure, it can become low. However, this end diastolic pressure, this low pressure inside the left ventricle, always rises in all forms of heart failure. In fact, it can go from a normal value of 10 up to as high as 30 or 40 or even 50 millimeters of mercury. The reasons that the left ventricular end diastolic pressure rise can be a little bit different depending on the type of heart failure. In systolic heart failure, less blood is pumped out of the ventricle, so more is left behind, and this raises the left ventricular end diastolic pressure. In diastolic heart failure, there is a stiff ventricle, and this leads to higher pressures. And I talk about the differences between diastolic and systolic pressure in another video. But the point I want to emphasize here is that no matter what the type of heart failure, the LVEDP will always be high, and this elevated left ventricular end diastolic pressure is the hallmark of left heart failure. And when the left ventricular end diastolic pressure rises, that will close the mitral valve at an earlier point in time before the left atrium has emptied. That will lead to a rise in the left atrial pressure. Shown at the bottom of the screen is Wigger's diagram, which I talk about in another video, but the dotted line here is the left atrial pressure, the solid line here is the left ventricular pressure, and those two pressures go together, and when the mitral valve closes right here, that's the left ventricular end diastolic pressure. So if that begins to rise, that will push up the left atrial pressure in turn. So in other words, when one chamber begins to fail and the pressure goes up, that leads to failure and rising pressures in the chamber that comes before it. So that means that once the left atrial pressure begins to rise, the pulmonary capillary pressures can begin to rise. And that can lead to two of the hallmark symptoms of heart failure, which are dyspnea and pulmonary edema. To help you understand this better, I've drawn a pulmonary capillary on the screen here, and it is the hydrostatic pressure, P sub C, in the pulmonary capillary that drives fluid out of the capillary and into the interstitial space in the lungs. So let's imagine that we have blood flowing into this capillary from the right side of the heart via the pulmonary arteries, and then we have blood exiting this capillary into the pulmonary veins and then going to the left atrium. So you need to understand that these capillaries in the lung are connected to the left atrium, so they see the pressure in the left atrium. So for example, let's imagine that the left atrial pressure were 5. This means that the hydrostatic pressure in the capillary would also be 5, and that would be the driving force pushing fluid out into the interstitium. Now let's imagine that this patient goes into heart failure, and instead of 5, the left atrial pressure becomes 20. Well, that means that now the pressure in this capillary is going to be 20. The hydrostatic pressure in this capillary is going to go way up. That's going to increase the driving force to push fluid out of the capillary and into the interstitial space in the lungs, and this is going to lead to pulmonary edema. So the key point here is that when the left atrial pressure goes up in heart failure, the hydrostatic pressure in the capillaries also goes up, and that causes pulmonary edema. And so now the process can continue to go backwards and affect more and more chambers. When the pulmonary capillary pressure rises, that can lead to a rise in the pulmonary artery pressure. And when the pulmonary artery pressure rises, that can lead to a higher pressure in the right ventricle. And when the right ventricular pressure rises, that can lead to a higher pressure in the right atrium. And remember that the right atrium is connected to the venous system. So right atrial pressure is the same as central venous pressure. So what this means is that a failing left ventricle via a domino effect of raising the pressures in all the chambers that come before the left ventricle can lead to high pressure in the venous system. This can lead to elevated jugular venous pressure in the neck veins, which is one of the hallmark signs of heart failure. We'll talk about that in a minute. It can also lead to capillary leak in the veins of the body, and that can lead to lower extremity pitting edema, another classic sign of heart failure that we'll talk more about in a minute. So now we can talk about the signs and symptoms of heart failure, which are fairly straightforward to understand if you understand the pathophysiology I just went through on the last few slides. First, I need to make a general point about the physiologic effects of lying flat. It's important to understand this in order to understand the signs and symptoms of heart failure. When you assume a supine position, in other words, when you lie flat, there is increased venous return to the heart. Basically, your legs are now parallel with the heart instead of below the heart, so more blood rolls back towards the heart. This leads to a redistribution of blood volume from the lower extremities and the splanchnic beds to the lungs. There's little effect of this in normal individuals with a normal heart, but in patients with an impaired ventricle, they cannot tolerate these changes, and therefore they will have a worsening of pulmonary congestion and breathing. And it's important to understand this in order to understand the classic signs and symptoms of heart failure. So when patients have left heart failure, meaning there are high pressures in the left ventricle and the left atrium, this will lead to dyspnea, especially on exertion, because there's high pressure in those pulmonary capillaries, as we discussed. This can also lead to a symptom called paroxysmal nocturnal dyspnea. This means a sudden awakening in the middle of the night feeling short of breath. It can also lead to orthopnea, which is the feeling that the patient can't breathe lying flat. Another classic presentation of heart failure is for a patient to have insomnia and be sleeping upright with several pillows behind them to feel better. When the right heart fails, meaning when there are high pressures in the right ventricle and right atrium, this leads to increased jugular venous pressure, as we discussed. That can lead to edema in the lower extremities. Basically, blood is pushed out of the capillaries of the body and gravity pulls it down to the lower extremities. It can also lead to liver congestion, and rarely this can cause cirrhosis. And these type of symptoms I've shown on the slide here are sometimes referred to as backward failure because they are all symptoms of blood backing up before the ventricle, not symptoms from inability to push blood forward. Now on the last slide I talked about signs and symptoms of right heart failure, and you should know that the most common cause of right heart failure is left heart failure. As I described earlier, when the left heart fails via a domino effect, the chambers that come before the left ventricle can develop high pressures, and this can in turn lead to right heart failure, and that's the most common mechanism of right heart failure. However, occasionally right heart failure occurs in isolation when there is normal left atrial pressure and the left ventricle is functioning normally. In these situations, there are high pressures only in the pulmonary artery, the right ventricle, and the right atrium. The pressures in the left atrium and the left ventricle are normal. This usually occurs secondary to a lung process. This is seen in pulmonary hypertension. It's also seen in COPD, and this is often called cor pulmonale. That means isolated right heart failure with a normal and well-functioning left heart system. Some other signs of heart failure that are more rare are called low flow signs and symptoms. These are symptoms of forward failure when the left ventricle is not pumping enough blood forward. These can include symptoms like loss of appetite because there's poor perfusion of the gut, so it doesn't feel good to eat. These patients can therefore lose weight. This is sometimes called cardiac cachexia. They can develop confusion from poor perfusion of the brain. They can develop cool extremities because blood is not being pumped to their fingers and toes. And they can have a very narrow pulse pressure. Your blood goes up to a systolic pressure and down to a diastolic pressure based on contractility. If you have severely impaired contractility, the difference between diastolic and systolic pressure can become very small. That's called a narrow pulse pressure. And these low flow signs and symptoms are seen only with a very low cardiac output in severe systolic heart failure. They're not seen in diastolic heart failure. And I talk about systolic and diastolic heart failure in detail in another video. The classic finding on auscultation of the lungs on physical exam in heart failure is called rales. As we described earlier, that high pulmonary capillary pressure pushes fluid out into the lungs, and then fluid-filled alveoli will pop open with inspiration, and this leads to the sound of rales. In addition, the chest x-ray can show congestion. At the bottom left of the screen is a normal chest x-ray. At the bottom right is a patient of mine with heart failure. Hopefully you can appreciate that the lung fields are relatively white and fluffy. That's a sign of fluid congestion. And you should be aware that the lungs and chest x-ray can be clear in patients who have a history of chronic heart failure. These patients often develop increased lymphatic drainage, and therefore they can potentially have a clear chest x-ray even when they are congested. Biopsy of lung tissue in heart failure isn't usually done in the modern era, but if you were to do it, the classic finding is the presence of heart failure cells. These are hemosiderin or iron-laden macrophages with brown pigment inside of them. There are some of these shown on the screen here. These develop because some red cells are pushed out of the capillaries, and then the red cells are engulfed by macrophages, and that leads to the presence of hemosiderin inside the macrophages. We talked before about how the pressure in the venous system can rise in heart failure when pressures in the chambers of the heart are high, and you can actually estimate the pressure in the venous system on physical exam. The way you do this is by placing the patient at about a 45-degree angle like I've shown on the screen here. You then examine the neck and you look for the A and V waves of the jugular venous pulsation. In another video on venous pressure tracings, I talk about how in the venous system of the body there are two waves called an A and V wave, and you can actually see this double bounce in the neck. So the way you estimate the jugular venous pressure is you determine the height of that double bounce. You then compare that to the height of the sternum. The sternum is 5 centimeters above the heart, and then you add on the number of centimeters to the height of that double bounce, and this estimates what's known as the jugular venous pressure. Normal is about 6 to 8 centimeters, so in other words, normal is for the double bounce to be 1 to 3 centimeters above the sternum. If the double bounce is much higher than that, that suggests elevated jugular venous pressure. Sometimes the double bounce is so high that it can't be seen because it's occurring up inside the skull. Other times it can be just below the earlobes, and sometimes you'll hear people say in the hospital that the patient's earlobes were bouncing. What they mean is the jugular venous pressure was so high that it was near the ears. There's also another abnormal finding that indicates high venous pressure that can be seen in heart failure. This is called the hepatojugular reflux. Normally when you press on the abdomen just below the liver, this will raise the jugular venous pressure, in other words, raise the height of that double bounce by 1 to 3 centimeters. In patients who have a failing right ventricle for any reason, the increase is greater. So if you see a rise in jugular venous pressure that is 5 centimeters or 6 centimeters, this is an abnormal response. It's abnormal hepatojugular reflux. I talked before about lower extremity pitting edema, but let's talk about that in a little bit more detail because it's a classic sign of heart failure. So just like there can be high pressures in the capillaries in the lungs, there are also high hydrostatic pressures in the capillaries of the body in general when there is heart failure. This can drive little bits of fluid out of all the capillaries in the body, and then gravity will pull that fluid down to the ankles and the legs, and this creates a finding called pitting edema. If you look at this picture on the bottom left side of the screen here, you can see the examiner presses his finger on the edema and then removes it, and that leaves a pit behind. That's why it's called pitting edema. This is a classic sign of heart failure. It's a sign of edema or extra fluid in the lower extremities. There are also some abnormal heart sounds that can be heard on cardiac auscultation of the heart. I discuss all of these sounds in more detail in the video on heart sounds. At the bottom of the screen, I've shown you the location of S1 and S2. An S3 is an early diastolic heart sound. It occurs just after S2. An S4 is a late diastolic heart sound. It occurs just before S1. An S3 is a sound that is abnormal and is associated with high left atrial pressure. In terms of board questions, if they tell you there's an S3, they're trying to tell you that the left heart is failing for some reason and the pressure is high in the left atrium. An S4 is a sound that is associated with a stiff left ventricle. This is more often seen in diastolic heart failure. And then finally, the apical impulse can be displaced when the heart is enlarged from heart failure. If you feel on the chest for the point of maximal impulse of the heart, it's normally located a little bit below the nipple. It can be pushed out laterally in patients who have an enlarged heart. And this is often another physical exam sign that's described in board questions to tell you that the heart is abnormal. Now let's get back to discussing the pathophysiology of heart failure. As I mentioned at the beginning of this video, all forms of heart failure lead to a reduction in the cardiac output. This in turn will activate two key physiologic systems. The first system is the sympathetic nervous system. It is always activated in heart failure. And the second system is the renin-angiotensin-aldosterone system. Levels of all hormones in the renin-angiotensin-aldosterone system rise in the setting of heart failure. And both of these systems in turn lead to two key effects that are present in all heart failure patients. This is an increase in the peripheral vascular resistance due to vasoconstriction and retention of sodium and water due to effects of these two systems on the kidneys. Let's talk some more about that first effect, the total peripheral resistance changes in heart failure. So as the cardiac output falls, in response, the body vasoconstricts to try and maintain blood pressure and tissue perfusion. In particular, angiotensin II is a powerful vasoconstrictor, and so is the sympathetic nervous system. What this means is that the total peripheral resistance is always high in patients with heart failure, and this is a high yield detail for you to remember for step 1 of the boards. Now, just because the TPR is high doesn't necessarily mean the blood pressure is high. Blood pressure in heart failure patients is often high, but it may be low, and that's because blood pressure depends on the combined effects of your cardiac output and your peripheral resistance. So for example, if the peripheral resistance is very, very high and the reduction in cardiac output is small, then patients with heart failure can have an elevated or normal blood pressure. On the other hand, patients who have severe end-stage systolic heart failure and have a very, very low cardiac output, these patients may be hypotensive despite having a very high peripheral resistance. Sodium and water retention is a very important element of the pathophysiology of heart failure. When the cardiac output falls, the effective circulating volume falls. In the renal videos, I talk about the effective circulating volume. It is the volume of plasma that is effectively perfusing tissues. When this falls because of low cardiac output, that activates a number of systems like the renin-angiotensin-aldosterone system, the sympathetic nervous system. It also leads to an increase in ADH release from the pituitary gland. All of these conspire to increase the sodium and water resorption from the kidneys, and that leads to a rise in total body water. And we've already talked about the rise in total body water. Patients with heart failure are congested. Their ankles are swollen, their neck veins are distended, their lungs are swollen. They have a rise in total body water. What's tricky to understand and what you need to appreciate is that even though total body water is increased, the effective circulating volume is actually down. These two systems are going in opposite directions. There's more fluid, but it's in all the wrong places, and the effective volume perfusing tissues is low. That's because of the fall in cardiac output, and it's that low effective circulating volume that activates all these systems. There are some other hormones whose levels change in heart failure, so let's talk about those now. The first one is ANP, which is atrial natriuretic peptide. When atrial myocytes are stretched, either due to pressure or volume overload inside the atrial chambers, this leads to release of a protein called atrial natriuretic peptide, or ANP. And ANP basically serves as a counter to the renin-angiotensin-aldosterone system. Unfortunately, it's not a strong enough counter to overwhelm the pathophysiology of heart failure. So all the things that ANP can do are the opposite of the renin system. For example, ANP is a vasodilator. It lowers the TPR. This counters the effects of angiotensin II, which is a vasoconstrictor. ANP can constrict the renal efferent arteries and dilate the afferents. If you look down at the bottom of the screen here, if we constrict these efferents and we dilate these afferents, that will lead to more blood going through the glomerulus and into the nephron. That will increase the urine output and cause a diuresis. So this is also the opposite of the salt and water retention that occurs with the renin-angiotensin system. So you can just remember that all the effects of ANP are basically the opposites of the RAAS system. I told you ANP is released by atrial myocytes. There is a similar protein with similar effects on the body that is released by ventricular myocytes. It is called BNP. BNP stands for brain natriuretic peptide. It has the word brain in it because that's where it was first discovered, but it's released by ventricular myocytes, and it's released in response to volume and pressure overload, just like ANP is in regards to atrial myocytes. Both of these hormones, ANP and BNP, serve as a counter to the renin-angiotensin-aldosterone system. You can just imagine how these evolved. When the renin-angiotensin system activates, salt and water is retained. That stimulates the release of ANP and BNP, which lead to loss of salt and water. So under normal circumstances, ANP and BNP can counter the renin system. Unfortunately, in heart failure, even though the levels of ANP and BNP rise, they're not able to counteract the deleterious effects of the renin-angiotensin-aldosterone system. And I should note here that a BNP level can be measured in the plasma, and this is sometimes used to work up patients who are short of breath and have dyspnea. If the level of BNP is high, it suggests heart failure is the cause of dyspnea. If the level of BNP is low, it suggests some other cause like pneumonia or some pulmonary problem is the cause of dyspnea. There is a drug called nicerotide that's very rarely used, but it is a recombinant version of BNP. It was thought to be beneficial because it would lead to vasodilation, it would lower the afterload, and potentially increase the cardiac output. Unfortunately, it's an expensive drug. It has to be given in the hospital intravenously, and in large clinical trials it was shown to have no real benefit. So this is now reserved for rare usages in patients who don't respond to other therapies. I'll finish with this slide and talk about how we make a diagnosis of heart failure. The most common way heart failure is diagnosed is by identifying the typical signs and symptoms in a patient. If a patient has dyspnea and rales and elevated jugular venous pressure and edema, that patient will receive a diagnosis of heart failure. As I mentioned before, an elevated BNP level in the plasma can be helpful for a diagnosis of heart failure. And then finally, I just want to mention that the definitive way to diagnose heart failure is to perform a heart catheterization. We don't do this very often because it's invasive, but in a heart catheterization, you insert a catheter like is shown on the screen here, either into the veins and the right ventricle and the pulmonary artery or into the arterial system, and you actually measure the pressures in the chambers of the heart. And like I told you before, anytime you see an increased left ventricular end diastolic pressure, that means there's left heart congestion and failure. Anytime you see an increased right atrial or right ventricular end diastolic pressure, that means there is right heart congestion or failure. So this is the definitive way to diagnose heart failure. It's only done in special circumstances, but for your board exams, they're going to want you to know that all these pressures can go up in right and left heart failure. And that concludes our module on heart failure basics.